or Maya.
Okay, so Angela and I will be discussing the implementation and evaluation of the Interact program at Baycrest Health Sciences. Okay, do I have to point it somewhere? Okay. So just to give you a brief overview of what we're going to discuss, I will give you some quick background information. Angela will go over Interact at Baycrest and her implementation experiences. Then I will wrap it up with our evaluation plans and some takeaway messages. So Baycrest Health Sciences is an academic healthcare delivery system that's fully affiliated with the University of Toronto. Baycrest is a hospital, a long-term care home that has 472 beds, also known as the Apotex. We have assisted living residences, community-based programs, outpatient medical clinics, and a research institute. So for this presentation, we're going to be focusing on the Apotex long-term care. So fundamental principle of Baycrest's strategic plan is to minimize disruptive and unnecessary client transfers to acute care. So like many institutions, Baycrest has met with challenges to increase the standards of care for clients with fewer resources. So in response to this need, Baycrest has identified a new model of care, capacity building, that will allow us to sharpen our focus on helping residents age in place and provide significant cost savings for the institution. So the objective of capacity building is to build the internal capability and interprofessional competence of staff and physicians to manage clients with greater clinical complexity in order to reduce and eliminate potentially preventable transfers to acute care. So capacity building is more than just Interact. It includes things like advanced care planning, transfer of accountability policy, and CCAC intravenous therapy services, but we will be focusing on Interact. And so also, just to give you some idea of what's going on externally, under the Excellent Care for All Act, the Ministry of Health and Long-Term Care is developing a quality improvement plan, and reporting for long-term care homes will become mandatory in 2015. So avoidable transfers to acute care have been identified as a provincial priority, and ED visits have been identified as a priority indicator. So we've made efforts to ensure that our capacity building initiatives and our implementation and evaluation align with this quality improvement plan. That was supposed to be gone. And so now I'll hand it over to Angela to tell you a bit more about the implementation.
Good afternoon, everybody. Okay, so Interact. I know Dr. Grabowski, he spoke about it this morning, but for those of you who don't know what it is, I will give you a brief introduction to it. Interact stands for Interventions to Reduce Acute Care Transfers. It's an American program, a quality improvement program. So it's not just a set of tools, but a whole program itself. And it assists in the identification, assessment, documentation, and communication of residents' changes in acute in condition. And in a study, it was implemented in 30 nursing homes, as he has mentioned. And the study that we referred to, they achieved a 17 to 24% reduction in preventable transfers to hospital. And just to note, please note reference to the Florida Atlantic University's Interact program in this presentation does not constitute or imply an endorsement or recommendation. However, it's a great program, okay? Okay, so Interact consists of 4 types of tools, but still remember, it's a program. There are advanced care planning tools, communication tools, which include the stop and watch and the SBAR communication form, decision support tools, and quality improvement tools, including the quality improvement tool for review of acute care transfers. This flowchart depicts how Baycrest chose to integrate the different Interact tools into our usual daily practice. It's not really usual daily care to transfer someone out to hospital, but just to give you a sense of where the different tools fit in. That's just a snapshot of what the overall flow looks like. However, I will break it down according to the identification and the management portion. So in the first piece, you see there is a resident who may come into the home, and that is when our own Baycrest medication reconciliation would be initiated. There are Interact medication reconciliation tools available. However, we're sticking with our own. There is also the Baycrest and Interact advanced care planning tools that would be implemented at that point. Now, if a resident were to experience an acute change in condition, the management of the situation can go in 3 different ways. One being the change in condition may not be identified, okay, that's subtle change, and the resident's change could worsen. Or the RPN or RN would be notified or notice the change themselves. Or third, the PSW would be the one who would identify that subtle change. From there, if the resident's condition continues to worsen, they would ultimately get sent out to acute care if that was a part of their wishes. If the RN or RPN became aware of this particular resident change in condition, they would do their assessment, and then from there, an Interact SBAR communication form would be initiated, and then they would call the physician as necessary. They would also document this on our Baycrest Transfer of Accountability Shift Report tool, which, by the way, there is a poster outside presented by Karen Ho, one of the advanced practice nurses, if you want more information on the Transfer of Accountability Shift Report. Now, the third route that we could go is if the PSW were to detect the resident's change in condition, they would initiate the Interact Stop and Watch tool, which I will explain further, and document on the Baycrest Transfer of Accountability form, which is the shift report. What would happen is they would submit this to the RN or RPN, an SBAR would be done, MD notified, and then they can choose whether they want to send this person out to hospital or manage them within the home. So now that you have a better understanding of what the Interact program is, I will talk about how we actually implemented phase 1 of this project. So phase 1 included rolling out Stop and Watch and SBAR Education, integrating the tools into practice, because education and integration are 2 totally different things in this case. And thirdly, the objective was to test and integrate the quality improvement tool for review of acute care transfers. So this is what the Stop and Watch tool looks like. I know that some of you may already know what Interact is and what Stop and Watch is and may have adapted it. Baycrest chose to keep this particular form, the original Interact form. And what it does is it's a tool for the PSW to use. If a condition is reported, assessed, and treated early, a potentially preventable transfer could be avoided. Traditionally, PSWs would report changes in status to the nurses verbally. This tool is to assist PSWs to identify and report these early subtle changes in the condition through a written document. So the Stop and Watch education was rolled out using 2 components, one, the classic in-service, and then also the practicum piece, so modeling it like you're actually going back to nursing school. So the in-service was comprised of a Baycrest-specific presentation, and that included, stimulating discussion with the staff, getting them to understand what the potential benefits are of trying to reduce transfers out to hospital, getting them to understand how it impacts the resident and how it impacts their own workload. Now, Medline University is an online curriculum. It's a website that has purchased the rights to deliver the education for Interact. In interest of time, because we all know that personal support workers' time is precious, I only chose some select slides and delivered it in more of a classroom style to support the Baycrest-specific presentation that was made. It took about 25 minutes. PSWs were engaged. The practicum piece is when the PSWs actually started filling out the tool. Okay, and I will describe the process flow in a moment. Daily check-ins were done by our advanced practice nurse team, as well as by myself, the project lead, and simple terms like, did you stop and watch today? Making it fun for them were utilized to help the staff understand that they didn't just attend an in-service and then it was gone. We actually continued with it. This process flow depicts how the stop and watch was integrated into the workflow of the PSWs. So what would happen is they would get their paper copy, which is living on the unit. We have a paper version of it, and it's a carbon copy. So there's the white copy on top, the pink copy at the bottom. And the PSW would identify that acute change in condition, complete the stop and watch tool, and then submit it to the RN or the RPN. Keeping in mind that this tool is not meant to replace verbal communication, okay? We don't want PSWs to think, okay, here you go, now go deal with it, right? You still have to stimulate that discussion. So the RN or RPN signs that they've actually received the tool, and then say they're in the middle of their 3-hour medication pass, they can put it on their cart and then say, okay, I have to remember to go follow up on this resident before I go home or whenever they find appropriate. Now, the pink copy goes to the PSW, who then in turn submits it to the unit director. Okay, there's a drop box at each communication desk. We are a large home. As Maya had mentioned, we are a 472-bed facility. So each floor has its own communication desk. So the PSWs would submit it to that drop box area, and then it's the unit director's responsibility to take a look at the pink copies of the stop and watch, see if there's something that she needs to follow up on, and then see if an appropriate follow-up was completed by the RN or the RPN. Okay, so this is the SBAR communication form. I know some of you may already know what SBAR is, but this is just an image of what the Interact tool looks like, which we are using. And this breaks down what's actually in the tool because you may not be able to see it. So the objective of the SBAR is to facilitate standard communication resulting in efficient and effective reporting from the nurse to the physician or even to the advanced practice nurse or another nursing colleague. The SBAR form prompts the nurse to prepare appropriate information on the situation, the background, the assessment, and the request. Now, in the Interact communication form, they break it down into specific sections and prompt the nurse to gather information, such as in the situation, it would include details about the change in condition. In the background, it includes primary diagnosis, medical history, medication alerts and vital signs, assessment of head-to-toe status changes, recent lab results, and advanced care planning information. The assessment includes the nursing's assessment of what they think is going on or their nursing diagnosis, and the request includes suggestions or recommendations for the care or treatment plan for that particular resident. So much in the same way, SBAR Education was rolled out, like the Stop and Watch tool education. So it was a two-piece, the in-service plus the practicum. So the in-service had the Baycrest presentation and a portion of the Medline University Module 7 curriculum. This one took a little bit longer because it didn't just include SBAR on its own. It introduced the concept of Interact, Stop and Watch, because they would be the end users receiving the Stop and Watch, plus the SBAR, okay? And for the practicum, the project lead, along with the advanced practice nurses, we would go in for daily check-ins and see how they're doing. We would do on-the-spot SBARs with them to make sure that they understand how to use the tool. And the unit director and the advanced practice nurses at clinical rounds would encourage the nurses to present their change in condition of the resident in SBAR format. So not just doing the form, but integrating it into their language. So what happens right now with the SBAR communication form is when an RN or RPN knows that there is a change in condition, they would assess the resident, okay? And they can also use the SBAR as a tool to support them during their assessment. And they would use it as a working sheet or a guide before calling the physician, okay? We have to remember that this is a paper tool. We do have an electronic health record, so it's important to emphasize that this document that we were using was for educational purposes, okay, for them to understand what comprises SBAR. So now when they complete that form, then they can call the physician and they can basically use that SBAR communication form as a script. The third piece that's part of phase 1 for our project is the quality improvement tool for review of acute care transfers. Now, I had mentioned before that Interact is a quality improvement program, and this tool actually ties all the elements of Interact together beautifully, okay? So it's not just the Interact tools, but also other nursing and vet interventions that could be discussed. So in this review tool, we would take a look at a resident who was transferred out to hospital and then take a retrospective look at, okay, what happened leading up to that transfer? What could we have done differently? Were there opportunities for improvement? So in this tool, it prompts the reviewer to review the resident characteristics, the acute change in condition, the actions taken by the staff before the transfer actually took place, including whether or not a stop and watch or an SBAR was used. It talks about the hospital transfer itself and, again, the opportunities for improvement. Right now, we are in our first PDSA cycle to see how we can actually integrate this into the workplace, because it does take a little bit of work to start the tool, initiate it, fill it out, okay? Because I see, according to the process flow that we're trialing right now, you would have the advanced practice nurse initiate the QI tool by chart review, filling out that form, knowing very well that the advanced practice nurse may not know the whole story, okay? So after that tool, you would have to really do a huddle with the care team. And I know it's difficult in terms of staffing to get the same staff who are working leading up to the transfer together at the same time. However, if you get a majority of the full-time staff together, you might get a sense, okay, was there something else going on? Did anybody notice anything? And then from there, we are gathering all the different QI tools that are completed. We're getting our quality, safety, and risk partner to collate the data so we can determine which of the transfers are the best for us to actually do a review tool on, because transfers still exist, they still happen. We just have to determine what's the type of criteria that we want to use to say, okay, this is an appropriate transfer to review. Please note, I understand that some other facilities don't have advanced practice nurses, or you have NLOTs or NP Stat. You don't need to have an advanced practice nurse to start this tool, okay? You could have a champion, you could have a point of care nurse, or unit manager can do it themselves. This is just the route that we had chosen. Okay, so if you're thinking of implementing Interact among all the other Interact tools there are, the first thing I would say is you really need to prepare, get to know what different types of tools are available to you, okay? Because you may choose to implement a different Interact tool. You may not choose to start with SBAR and stop and watch. There are other things, okay? So just as a general, to give you a general idea, education preparation takes about 1 to 2 weeks. The pilot period took about 4 weeks, from weeks 3 till 7, and then spread to the remaining units, and again, a larger facility, took up a better part of weeks 8 to 18. Right now, we are in this period of weeks 20 to 27, week 25 to be exact, and we are reviewing that PDSA tool. And ongoing, as everything, the sustainability plans have to be kept up to date and reinforced to make sure that these tools continue to be used. This timeline was not created on my own. We had a capacity building working group. Together, we had decided which tools to start with. The communication tools were the biggest bang for our buck, so we started with that, and the timelines were decided accordingly. Okay, so I'm proud to say, it's great to work with an evaluation team, because it actually enhances the implementation piece, because you feel like, oh, I have to do things properly, right? Because someone's going to evaluate it. So Maya's going to speak to the evaluation piece. I'll just get this up.
Thanks, Angela. Okay, so for our evaluation, we had 1 primary and 3 secondary objectives. So our primary objective is to determine the frequency of potentially preventable transfers from the Baycrest long-term care home to acute care facilities following the implementation of Interact and other capacity building strategies. And our secondary objectives are to describe the frequency with which patients are experiencing acute changes in status and the proportion of those patients who are sent out to acute care, to describe the conditions and circumstances that either precipitate or prevent a transfer to acute care, and to describe the care staff's experiences with Interact and the capacity building implementation. Thank you. Okay, so we are still very much in the planning and piloting phase. So we don't have any data to share today. We're just kind of sharing what we've been doing to gear up to conduct the evaluation and what our plans are for the future. We hope to be able to share some data with you in the near future. So the first few steps were we conducted a pretty thorough literature search and got our REB approval. We began developing our study measures, so that included creating our own measures like surveys and interview guides, as well as coordinating with other groups at Baycrest to access data that was already being reported and perhaps adjust the reporting to suit our needs. We also conducted some preliminary staff surveys and kind of got the ball rolling on receiving regular reports of data, like transfer data. So right now, we are currently piloting our chart review and our audit protocol, and we are going to be conducting some staff interviews very shortly. So our main outcomes focus on 3 areas. 1 is transfers, 2 is acute changes in resident status, and 3 is staff experiences. So for transfer data, we'll be looking at the rates of total transfer as well as potentially preventable transfers before and after the implementation of Interact and capacity building. Our acute change data will focus on the number of residents who are identified, as well as what kinds of tests and treatments they're receiving on site, the proportion of those residents who are transferred to acute care, what kind of communication with the physicians is taking place, and what's the outcome of their transfer to acute care. And our staff experience data will include readiness for change, barriers and facilitators to change, perceived effectiveness of Interact, as well as knowledge acquisition related to Interact. So our first group of outcomes was transfer data, which will be collected from the Baycrest Shift Census Worksheet. So the shift census worksheet is where all admissions, discharges, transfers, and leaves of absence are documented. This is completed on every unit in the hospital and the Apotex, and it's completed every 8 hours. And it's all submitted to our medical records department where the data is collated. So we did make revisions to the shift census worksheet to facilitate our evaluation. The first was we're now requiring staff to document whether the transfers are planned. So a planned transfer would be something for a scheduled appointment, like an elective surgery or chemotherapy. And we also made revisions to the reason for transfer, the way that the reason for transfer is documented. So currently there's a legend on the census that lists a few of the more common reasons why our residents might be transferred. So we've updated that legend so that it includes more of the potentially preventable reasons. So this reason for transfer documentation is what we will use to identify the potentially preventable transfers. So this terrifying table is a bit of an illustration of how we're going to define what is a potentially preventable transfer. So that was one of the first questions we had to ask ourselves. Typically, you would use the condition that is most responsible for the transfer to acute care. So we conducted a literature search, thought it would be easy. We just find a list of conditions that we could use. But as you can see, there's little consensus on a standard list of conditions. So Interact has a list that they provide with their program that you can use to calculate your rate of potentially preventable transfers. ACSCs are a more common way of defining transfers. So ACSC is an ambulatory care sensitive condition. The only issue with ACSCs is they're typically not geriatric focused. So our third option is ANHACs, which are nursing home avoidable conditions. So they're more focused on the geriatric population. So those are sometimes combined with the ACSCs. So as you can see here, all of these conditions listed here were indicated in one of the three sources. So what we've decided to do is take a more cumulative approach and use all of these conditions at the start and kind of see how it goes. And if we approach it this way, we can analyze our data in a few different ways. So we can take out all of the Interact-specific diagnoses and analyze our data so that we can compare it to other Interact data. We haven't started this phase yet, so we've been collecting our transfer data, but we have yet to start classifying our transfers as potentially preventable. So I'm not sure how it'll go, so we'll see. We may have to make some adjustments to this list. So our second group of outcomes is related to acute changes. And the acute change data will come from an audit of the TOA shift reports that Angela was referencing. Those are used by PSWs and nursing staff to report changes in status of residents as well as any other important information, and as well as a chart review of electronic health records. So the audits will be conducted bi-monthly on the units, and we will be reviewing the shift reports to identify any residents who have been documented as having an acute change. And we will also look at how is that change being documented? Are the PSWs and the nurses reporting the same kinds of things? We did also have to make some revisions to the TOA form. We worked with that team to facilitate the evaluation. One thing that we did do there is that the staff will now document if the change in status is a new change or if it's just ongoing monitoring for something that was identified, say, the day before or last week. So we will take a subsample of the patients or the residents that we identify through the audit for chart review. And we're going to review the charts for 14 days following their first sign of an acute change. And we're going to collect data related to the treatments that they receive, for example, oxygen therapy, IV fluids, and we'll look at the tests like blood work, urine cultures. We'll look at assessments and referrals and communication with the physician. We'll also collect some basic demographics and resident characteristics. If the resident is not transferred out by the end of the 14 days, we will assume that they were treated successfully on site. And our third group of outcomes is our staff experience data. So this data will be collected via surveys and interviews. In terms of surveys, we've already conducted a brief readiness for change survey prior to the interventions. That was done with unit managers and APNs. We're also distributing surveys to assess knowledge acquisition related to Interact. So this takes place during education sessions with the nursing staff. And we're also going to be surveying the physicians to get some feedback on their communication with the nurses, specifically related to the SBAR tool. Interviews will be conducted one-on-one with PSWs, nurses, physicians, and managers. So we'll try and get some information there about their perceptions of the effectiveness of the tools, any challenges they've experienced in implementing, and their thoughts on if they've seen any changes in the transfer rates and why they think they may be seeing those changes. So just a few takeaways. We wanted to try to come up with some things that might be useful for other homes or other facilities who are hoping to either implement Interact or interact with an evaluation. So for us, I think the real focus here was on collaboration. So this was one of the first evaluation projects that we've seen at Baycrest where the implementation and the evaluation team really worked together from day one. And that's really been quite apparent in how we've been able to collect our data. So as I was saying, some portions of the implementation have been adjusted to facilitate the evaluation team. So that's really made a big difference for us. The second is something that Angela touched on. So just recognizing that your institution is unique and that you may not need to start your implementation with Stop and Watch and SBAR like we did. So just think about what works best for your institution and don't be afraid to approach it in a different way. And then once you've figured out how you're going to approach it, pilot testing is really important. So this will help you gauge what the learning needs of your staff are and also create a plan that you can integrate into your daily workflow. And then the last one is utilizing existing infrastructure. So for the evaluation team, this was really key, was finding sources of data that we could easily mine, so data that was already being collected and reported, and we could just make minor adjustments where we needed to, for example, with the transfer data. Also using educational sessions as opportunities to distribute surveys, and committee meetings to get feedback from staff. So that's it. That's our reference.